Hello, everyone, and thank you for joining us. It is my pleasure to introduce our speaker today, Dr. Sarah Buss. Dr. Buss obtained her PhD in microbiology at the University of Virginia, Charlottesville, followed by a CDC APHL postdoc in the Wadsworth Center's Tick-borne Bacterial Diseases Laboratory. She completed her clinical microbiology fellowship at the University of Nebraska Medical Center and Nebraska Public Health Laboratory. Past roles have also included CLIA Director at the Colorado Department of Public Health and Environment, as well as Laboratory Director at the Wyoming Public Health Laboratory, Wyoming Department of Health. Since 2018, Dr. Buss has been the Clinical and Molecular Microbiology Director at Northern Light Laboratory, where she directs microbiology testing in a reference laboratory that serves more than 9 hospitals and 250 outpatient practices. The title of her talk today is Identifying the Tick-borne Pathogens That Summer in Vacationland. And with that, I would like to turn this over to Dr. Sarah Buss.
Thank you so much for that introduction. I'm really glad that we were able to put something together, even though this isn't the way we planned to deliver this presentation. But I think that even with all that's going on today with COVID, tick-borne pathogens are still important and relevant topics, especially in certain geographic areas, one of which is mine. So in case you didn't catch the reference in my title, Vacationland is a reference to the state that my lab primarily serves, and that's the state of Maine. Vacationland is a motto that you'll find on our highway signs and our license plates and other various advertisements for our beautiful state. I wanted to run through a few fun facts about our state that may help you understand the Vacationland mantra. Maine has a relatively low population with 1.3 million residents, but we have about 37 million tourists that descend upon the state each year. The tourists usually squeeze their visit into the summer and fall months when the weather's at its peak and the blueberries and lobster are plentiful. But even though they squeeze their visits into that relatively small window, there's still a lot of room to spread out because geographically, Maine is larger than the rest of New England combined, so meaning larger than Rhode Island, Massachusetts, Connecticut, Vermont, and New Hampshire. We have over 500,000 acres of state and national park land, and believe it or not, we have more coastline than California at almost 3,500 miles. In general, we're a very wet state. We have 32,000 miles of rivers and streams, and I think that probably includes Poland Spring, which I'm guessing you guys heard of. We also have a large number of lakes and ponds where every true Mainer has a camp. Not me yet, anyway. Maine also has a ton of trees, and we're actually considered the most forest-covered state, with 89% of the state being considered forest lands. So perhaps by now you realize there's a reason I'm giving you all these facts about Maine, and it is to prove to you that the wet, forested state, with its abundance of outdoor opportunities and outdoor enthusiasts, makes a great habitat for ticks and the tick-borne pathogens that they carry. So it turns out it's not just beaches and blueberries and lobster. Ticks are a significant problem in Maine, and they're a public health problem. So this slide is a screenshot from the Maine Center for Disease Control and Prevention's super cool data portal. On this website, it's via the Maine Tracking Network. They display the number of Lyme, Anaplasma, and babesiosis cases in what they call near real time. And they obtain these statistics through the notifiable disease surveillance data, which includes data supplied from my own lab when we detect any of these diseases in a patient. First, when I first put these slides together, they didn't have the 2020 data up yet, so this is 2019 data. But when I checked just yesterday, there were 2020 data available, and we already had registered a few hundred cases of Lyme, about 50 cases of anaplasmosis, and a handful of babesiosis cases for 2020. And so what you see here and what I just described is pretty typical. We tend to see more Lyme than anaplasmosis and more anaplasmosis than babesiosis. But both anaplasma and babesia are increasing, and it's hard to say whether that's because of improved diagnostics or the fact that they are increasing in prevalence in our state. Another great surveillance program in the state of Maine comes out of the University of Maine's Cooperative Extension Program. They offer a tick identification service where you can send them the ticks you find, and they will identify them to the species and life stage level for free. So you send in the tick along with the location where you believe the tick came from, and it winds up as a dot in their map. They also have a diagnostic service that we'll talk about in just a minute, and their map is now interactive. So you click on a location, and you can see what kind of ticks were found at that location, and as we'll discuss, you can see which percentage of ticks were harboring which pathogen. So on this slide, you can see that that the ticks they received were primarily Ixodes scapularis, or the deer tick, and a little bit of dog ticks were received. Fortunately, they did not see a lot of woodchuck ticks. These are the most common ticks that carry powassan, which is a scary virus. I'm not going to really talk about that today, but fortunately they didn't see a lot of them. And they also didn't see a lot of Lone Star ticks, which can be important vectors of disease. So in this map, you can see that the ticks they received were primarily received from the southern and coastal parts of the state. And obviously we can't say that those are the locations that have the most ticks, because they only get data points when somebody actually sends them a tick and notes where it was located, and obviously there's bias and subjectivity associated with that. But at minimum, this shows us that there are many ticks located in these areas in Maine. So it was mentioned in the introduction, but just to give you a little bit of background about my laboratory, Northern Light Laboratory, we are a reference lab for the Northern Light Health System, which includes the 10 hospitals that are shown on this map. The star is Eastern Maine Medical Center, and that's where our lab is physically located. In addition to serving our health system, our clients include other hospitals in mostly mid and northern Maine, as well as providers' offices that are scattered throughout the state. And if you remember back to the last slide, the location of the ticks that University of Maine Cooperative Extension received, the most tick-laden locations line up nicely with the location of the populations that we serve in these hospitals. So I mentioned there was a diagnostic service associated with the University of Maine's Cooperative Extension Program, and they provide the tick identification for free, but for $15, yeah, really $15, you can have your tick tested by PCR for a panel of organisms that's most appropriate for the tick species that you sent in. And this is because different tick species are known to harbor different pathogens. So for Ixodes ticks, they will test for Borrelia Burgdorferi, the bacteria that causes Lyme disease, Anaplasma Phagocytophylum, which causes anaplasmosis, and Babesia microti, the most common species of Babesia to cause babesiosis in the U.S. For dog ticks and the Lone Star tick, they'll test for Rickettsia rickettsii, Ehrlichia species, and Francisella tularensis. And what you're seeing in this slide is last year's data. And that's because the current year's data is not quite available yet or nearly as interesting. And the data here is specific to Ixodes ticks or deer ticks. And that's another reason for that is because the non-deer tick panel is new to 2020, so that data isn't available yet either. So what you can see for the Ixodes ticks in Maine is that 44.9% of them were positive for at least one pathogen, and 7.3% were actually positive for more than one pathogen. You can see that Borrelia Burgdorferi was the most commonly found pathogen, with almost 39% of ticks being positive for it, and that can be further broken down into tick life stage. And you can see that adults are typically infected more often than nymphs, which makes sense because they have the opportunity to become infected with each blood meal, and at an adult life stage, there would be more blood meals taken. So for Anaplasma, you can see that about 8.1% of ticks were infected, and for Babesia, it was 6.1% of ticks. Now, as a good scientist, a good clinical microbiologist, I feel the need to point out that you can't test a tick that bit you to determine if you have a tick-borne disease, right? Just because the tick that bit you was harboring a pathogen doesn't mean they passed that on to you and you got disease. And just because you found a tick on you that didn't have a pathogen doesn't mean that you weren't bitten by a different tick and didn't have it. But I still think this data is important because it shows that these pathogens are present in strikingly high percentages of ticks in the state of Maine. So in 2020, they have expanded their Ixodes panel to include Borrelia miyamotoi, an organism known to cause tick-borne relapsing fever. There are other published studies to show that this organism is present in Maine, so I assume they're going to find it. And I'm actually really excited to see what they do find. I think that will help me determine what's best to do in my laboratory. And in 2020, they also, like I mentioned, added this non-deer tick panel to look for some of the pathogens that are present in other types of ticks that they do find, and this includes Ehrlichia chaffiensis that we'll talk about a little bit. All right, so now we know Maine has a lot of lobster. You guys knew that. A lot of tourists, a lot of outdoor enthusiasts, a lot of ticks that carry pathogens. We'll just take a quick look at some of the pathogens and the diseases that they cause and talk about general details related to diagnosis. So first up, Borrelia Burgdorferi, the organism that causes Lyme disease, most commonly in the U.S. There are other species of Borrelia that cause Lyme disease in Europe. But again, Borrelia Burgdorferi is known to be the most prevalent pathogen in ticks in Maine, and Lyme disease is the most common tick-borne disease in Maine and the rest of New England as well. I'm sure that you're familiar with the story of Lyme disease. A percentage of patients experience the expanding bullseye-shaped rash or erythema migrans that's associated with Lyme disease. And this rash is actually considered diagnostic, especially in areas of high prevalence. However, it doesn't always appear. So we still test for it. We still test for Lyme disease a lot. And currently, a two-step serology is the most widely used method for diagnosis. It's not perfect. We could have a whole week-long seminar about Lyme testing and get in lots of fights about it. But currently, two-step serology is what's used. It's the best method we have, and it's actually, interestingly, recently evolving from some type of screening assay followed by confirmatory Western blotting to possibly a screening immunoassay followed by a confirmatory immunoassay and no Western blot. But that process is, like I said, new and evolving, and I do imagine that dropping the confirmatory Western blot will become more widespread with time. But I think that serology will be the main method used to diagnose Lyme for a while anyway. And that is because PCR, which usually has a high sensitivity for an infectious disease, has actually limited sensitivity when we're talking about Lyme. And this is probably due to the fact that the organism doesn't spend a lot of time or get to a very high load in various specimen types that are typically used for PCR. PCR does tend to be used to diagnose Lyme disease more frequently in synovial fluid and sometimes CSF rather than blood, because especially synovial fluid tends to be a better sample type for PCR. But again, it's still not incredibly widely used. In terms of treatment, doxycycline is a treatment of choice, but if treatment isn't started early, then it can get pretty complicated. So Anaplasma Phagocytophylum, another bacteria that's transmitted by Ixodes scapularis ticks, especially on the East Coast, and Ixodes pacificus ticks on the West Coast. This organism does have a tropism for granulocytes, particularly neutrophils. And an older term for the disease caused by anaplasma is human granulocytic anaplasmosis, or sometimes even human granulocytic ehrlichiosis, because it used to be difficult to distinguish anaplasma and ehrlichia and the diseases they cause. However, now we call the disease caused by Anaplasma Phagocytophylum anaplasmosis. And symptoms of anaplasmosis tend to be pretty nonspecific, and they include things like fever, chills, severe headache, muscle aches, as well as GI symptoms that can include nausea, vomiting, and diarrhea. Rashes are sometimes reported, but these may indicate co-infection rather than, a sign of anaplasmosis. Later in the course of an untreated infection, symptoms may progress to hemorrhage, respiratory or organ failure, or even death, which is really rare, but it can happen. Laboratory findings in the setting of anaplasmosis include thrombocytopenia, leukopenia, maybe even pancytopenia, and elevated liver enzymes. In terms of a diagnosis, you can sometimes, if you're lucky, see anaplasma on a blood smear, but this really lacks specificity and sensitivity. It's really kind of fun when you see it, and technologists in areas with a high prevalence do get good at picking out what we call the morula, or what are actually like bacterial clusters within the usually neutrophils that they're infecting. But again, blood smears lack sensitivity. They're not usually specifically ordered for detecting anaplasma. It's more of an incidental finding if you do see it. PCR from whole blood is really the most sensitive method for diagnosis of anaplasmosis during the first week of illness. And PCR may be useful beyond that first week, but sensitivity does wane. Serology is kind of the reverse, where it's not helpful during the first week of illness, and it does require paired acute and convalescent samples collected 2 to 4 weeks apart. And, as with a lot of serological assays, there are specificity issues, and it is sometimes hard to interpret a serological result, hard to distinguish a current from a past infection. Doxycycline is an effective therapy for anaplasmosis, especially when it started early in the course of infection. And actually, presumptive treatment with doxy is recommended for patients of all ages suspected of having anaplasmosis, even in young kids. So Babesia species are parasites, apicomplexan parasites, that are transmitted by Ixodes scapularis ticks. And in the United States, the most commonly identified Babesia species in these ticks is Babesia microti. We call the disease caused by Babesia babesiosis, and babesiosis can occur months, weeks to months after exposure, and reoccurrence can actually happen. Symptoms can be mild, but again are nonspecific and include things like fever, chills, body aches, nausea, and generalized fatigue. Babesia parasites do destroy red blood cells, and they can lead to hemolytic anemia with the associated symptoms of jaundice and dark urine. The infection can be severe and include organ failure, disseminated intravascular coagulation, and even death. Severe disease is more common in people who lack a spleen or are otherwise immunocompromised. Labs may indicate thrombocytopenia, which can be quite severe, or hemolytic anemia, as well as elevated liver enzymes. And in terms of a diagnosis, this can occur via a Giemsa-stained blood smear. Blood smears are time-consuming and they can lack sensitivity, but they can also be performed pretty quickly and used to monitor percent parasitemia, and that can be useful in certain settings. PCR from whole blood is a good choice, again, during the acute phase of infection if PCR is available. And the situation for serology with Babesia is very similar to that of anaplasma. Serology is not helpful early in the infection. It requires paired acute and convalescent samples, has associated specificity issues, and can be hard to interpret. Treatment for Babesia is not doxycycline. It includes atovaquone and azithromycin or clindamycin plus quinine. So, in our laboratory, we do perform a lot of serological testing for Lyme disease. We do our own Western blots, but I'm not really going to focus on that. I'm going to talk about the molecular testing that we do. So I have some data up here that is from my lab from the period of June 2018 through December 2018. And I chose that time frame not necessarily because it's our tick season. Our tick season is more like April through November, but as you'll see, I have some 2019 data to compare to this data for that same period of time. So anyway, in this period of 2018, we sent out over 1,500 samples for some type of PCR. Most commonly, we were sending out samples for what we call a tri-panel. This is for Anaplasma, Babesia, and Ehrlichia. And of those samples that we sent out for a tri-panel, about 3% were positive for Anaplasma, and 0.3% were positive for Babesia. Sometimes, less frequently, samples were sent out for just Anaplasma and Ehrlichia PCR. And again, we had about a 3% positivity rate for Anaplasma. Occasionally, samples were sent out exclusively for Babesia PCR when there was a high suspicion for Babesia specifically. And of those, we had a small number that were positive, but it was a relatively high percent. Of all the samples that we sent out for PCR, we had about a 0.5% positivity rate for Babesia and about a 3.1% positivity rate for Anaplasma, and we saw no Ehrlichia. In the same period of time, we sent out somewhere around 800 samples for Anaplasma and Babesia serology. Some of those samples were the same sample that was getting tested for both, and some were not. But a reasonably high number of samples sent out for serology, with some associated positivity there. And in our laboratory during this period of time, we also performed 88 blood parasite smears, 23 of which were actually positive for Babesia. However, those 23 positives actually related to only 3 patients. Our providers really like to follow the percent parasitemia in Babesia patients. And actually, during this period of time, we had a patient who had no spleen, who had a pretty severe case and got better and then had a recurrence. And so he probably makes up the bulk of those 23 positives. But anyway, the send-out molecular testing alone that I'm talking about on this slide cost us over $500,000 to send out. And the turnaround time that we received was less than ideal. And that's especially due to time in transit. Remember, we're a reference laboratory ourselves. And even though all of our hospitals are serviced by multiple couriers each day, they still have to get us samples, and then we have to get the samples to another lab if we're sending them out. And that just takes too long. Another smaller issue that we noticed when we kind of evaluated the situation was that we had a relatively high number of patients for which molecular testing was repeated multiple times in quick succession in a way that we didn't think was clinically meaningful. And so for some of these reasons, cost, turnaround time, having more control over what was going on, we decided to consider bringing an assay in-house. And when we looked at our options, we quickly realized that there weren't many options and that we would be looking at an LDT. And that's okay. We're not adverse to LDTs in our lab, and we have a pretty good amount of experience with them. And so in terms of working through the different components of the assay, we have a nucleosense EasyMag, and we had experience with extraction from blood. So it seemed like that would be where we landed in terms of a nucleic acid extraction. And at the time, we also had 3 liaison MDX thermocyclers. And we knew that DiaSorin had Anaplasma, Babesia, and Ehrlichia analyte-specific reagents available. I will say for a moment, we considered other options. As you heard, I previously worked in a tick-borne disease lab, and when I worked in that lab, I had developed an assay for Anaplasma and Ehrlichia and worked closely with one for Babesia. But my lab didn't really have a standalone thermocycler, and we also didn't have good options for making our own internal control. I had previously cloned our internal controls, and my laboratory is not set up for cloning. So we decided that moving forward with the DiaSorin ASRs and their sample extraction and amplification control set was really our best, most reliable, and fastest option. We also look to use the TA master mix and the universal disk for a complete assay setup. And I knew we would need positive samples, which we'll talk about in a minute, but I also knew we would need something quantified to be able to do our limited detection studies. And when we were working on this, Exact Diagnostics was unable to supply material for all 3 organisms, and I didn't want to wait for them to be ready. I think they have material now, but they didn't at the time. So I moved forward by ordering full-length synthetic genes from Thermo Fisher. This is their Gene Art Strings product. And this worked well because I knew which genes these ASRs targeted, but I didn't know which regions of the genes. And these Gene Art Strings, they can be made long enough to cover the entire gene. And, also I really love doing LOD studies with genetic material because they tend to come out exactly as you expect. And what I mean by that is as opposed to using a bacterial cell, starting with genetic material to spike your samples, it tends to come out much more exact because you can quantify it better, in my opinion. So anyway, I ordered the Gene Art Strings, and we began the process of assay validation. As you know, it's a requirement before you use any assay clinically to validate it, and the requirements are more stringent for assays that are considered laboratory developed. We decided that we would have to offer each assay individually as well as offer a multiplex. So we started, with the idea to do our validations that way as well. Unfortunately, we were validating this assay in the winter, and we didn't have any of our own samples to use for validation at this point. I know that you can spike samples to use for your validation if you wanted to, but that synthetic genetic material that I had purchased kind of makes the non-ideal process of spiking even less ideal, so I really, really wanted to get at least a few positive samples for the validation. And I reached out to every large reference lab that you can name to ask if we could buy positive samples, and I had no luck. I contacted the speakers from DiaSorin seminar last year, but they also didn't have samples in the winter. My DiaSorin reps couldn't find me any samples in the winter, and so eventually I just decided to go home to Albany, New York and visit my parents and go to my old lab at the Wadsworth Center and beg people there to raid the freezer for me. And fortunately, they're super nice people there, and they like me, I think. So I was able to get a handful of weak to moderate positive samples from them. And I was also able to score some nice samples for specificity studies, including a variety of Plasmodium positive samples. In addition, it was getting later in the winter and ticks were emerging. So ultimately, we were able to get a few of our own positive samples sent back to us from the reference lab that we were using at the time. To round out the study, we did wind up spiking samples. We used purified nucleic acid from the real samples we got for spiking, as well as some of the synthetic genetic material. Spiking was done after the LOD studies and after testing the original samples, so we could be sure that we were spiking at levels that were kind of near the LOD. You know, honestly, I would have loved to have more real samples in this study, especially more real Ehrlichia samples, but it just wasn't possible, and we did the best that we could with what we had. So for the accuracy part of the study, we wound up using a total of 56 samples. It was 39 positives and 17 negatives, and again, those positives were partially spiked, partially real samples. So when I make up these kind of tables for my multiplex assays, I always make sure I include the results from all targets in the table. So what that means is what you're seeing here is 3 results from each sample. So a multiplex assay for Anaplasma, Babesia, and Ehrlichia, by definition means that an Anaplasma positive sample is negative for Babesia and Ehrlichia, and a negative sample is negative for all 3 analytes. So when I write up the validations, I do break these tables down, but what's shown here is a table that represents all the results for all the samples and all the analytes in our accuracy portion of the study. I mentioned that we validated singleplex assays as well as multiplex, and the results that you're looking at are from the multiplex. In the singleplex assays, everything worked exactly as expected. So as you can see, we wound up with pretty good results, a sensitivity of 97.4% and specificity of 100%. We had one spiked Babesia sample that tested negative in the multiplex PCR, but positive in the singleplex Babesia PCR. When we repeated that sample, it was positive with a CT of 34.1 in the multiplex PCR. Not really sure what happened the first time around, but again, we were spiking. It was a spike sample, and we were spiking kind of near the LOD. So I didn't show the data in this talk, but we also performed reproducibility and precision studies where we repeatedly tested the same samples in the same run, as well as repeatedly tested the same samples in different runs with different operators, and we obtained excellent results in all of those studies. Even to this day, honestly, I'm still amazed at how consistently our control material performs. The CTs hardly move between the runs, even over months. For our LOD studies, we spiked synthetic genes into whole blood at known concentrations, and then we made 10-fold dilutions. And once we landed on what we thought would be the LOD, we tested that concentration repeatedly. And you can see that for most analytes in both the singleplex and the multiplex assay, the LOD came out to be the same, 18 gene copies per test. The exception was for Babesia. The singleplex assay actually wound up missing a replicate, and the LOD was determined to be 180 copies per test. We thought about increasing the amount of replicates we tested to make missing the one at 18 gene copies per test acceptable, but we decided against it. We were comfortable with the LODs that we obtained here. We also performed specificity and interference studies. We tested samples that contain known blood-borne pathogens, including a variety of different bacterial species and samples known to be positive for the various Plasmodium species that I mentioned before. We also spiked icteric and lipemic specimens, the worst ones that we could find, actually, and determined that there was no effect on the ability of our assay to detect analyte in those samples. We also spiked samples containing various over-the-counter medications, things that you might take if you had, headache and muscle aches. And we showed that there was no effect of those on our ability to detect the analytes either. So after we went live with the assay, and after we completed the validation, we went live with the assay. And this is our data from June through December of 2019. Our volume almost doubled from the year before. So if we had to send out this volume of tests, it would have cost us over $1 million. And instead, we spent about $150,000 on reagents. And importantly, we were able to reduce the turnaround time by days in some instances. So the percent positivity for Anaplasma, it went up slightly from 3.1 to about 3.9%. And Babesia also went up from about 0.5 to 1%. I really don't think that had anything to do with the assay, but of course I really can't be sure of that either. And we still saw no Ehrlichia in our population. The number of blood parasite smears we processed went down a little bit from 88 to 58. We still had requests to follow the same known positive patients in order to get the percent parasitemia over time. We also noticed that requests for serologic testing declined, as did the number of patients that received what we deem to be inappropriate repetitive testing or duplicate orders. We were really happy with how this transition went. We had to provide some education to our physicians about ordering practices and even, about prevalence of these organisms in our population. We had some providers who thought that we have no anaplasma but lots of Ehrlichia. We had to, educate them. But overall, we were really happy with how this transition went, and so were our physicians. So I just have a couple cases to illustrate kind of why our physicians were happy. So this is a case where an 83-year-old man was found on the floor by his son in the summer, and he was brought in, and they learned that he had experienced about 2 to 3 weeks of fatigue, body muscle aches, dry cough, along with shortness of breath. Eventually, he had a high fever and confusion, and these symptoms were all described as worsening. And it turned out that he was in hypoxic respiratory failure, bilateral lung infiltrates. He had AFib, also renal failure, pancytopenia. His white cell count was 3.3, platelets 45, hemoglobin 7.4. He had hemolytic anemia. So, I think if we were guessing what was going on, the fact that we're talking about tick-borne pathogens and this guy has hemolytic anemia, it should be a big clue. They did order a tick panel, so Anaplasma Babesia and Ehrlichia PCR testing, as well as Anaplasma Babesia and Lyme serology. Obviously, these aren't the only tests that they ordered, but these are the relevant ones. And these were ordered pretty early on in terms of his presentation, and they were actually received by my laboratory at about 1:30 in the afternoon on the day that he presented. And that's even though he presented to an outside hospital. So at the initial facility that he visited, he was given a dose of Doxycycline and Zosyn, and then he was transfused. And a while later, he experienced a transfusion reaction, and he was transferred to our facility at about 9 p.m. But by that time, we knew he was PCR positive for Babesia. And actually, parasites had also revealed themselves on a blood smear. But our evening shift doesn't provide percent parasitemia on blood smears. That was done the next day by our day shift, but the sample that was obtained at presentation had a 7.5% parasitemia. I really should know, but I don't know what the CT of that original PCR was, but my guess would be that it was really low. Because something that we did experience was that when you had a positive PCR with a CT higher than, I don't know, anywhere from like 27 to 32, you may not see positivity in a blood smear. And that was actually something that we wound up having to explain quite frequently last summer. I mentioned that our providers like to follow their positive patients with blood smears, so something that we didn't expect was we would get a positive PCR, and then the provider would order a blood smear to determine the percent parasitemia, and the blood smear would be negative, and we'd have to explain why. And we'd look to the CT, and inevitably, if it was a high CT, it wouldn't be positive in the blood smear. So anyway, long story short, my guess is that this guy had a really low CT on his PCR for Babesia because he was quite positive in the blood smear. Anyway, an important point is that he was originally treated with Zosyn and Doxycycline. I'm thinking they were thinking sepsis and something like Anaplasma or Lyme. He really did have Lyme, actually. It was a co-infection. We didn't know he had Lyme until later the next day after he presented when the Western blots were completed. So he did need that doxy, but the treatment that he was originally given was not a treatment for Babesia. So as soon as the Babesia diagnosis was known, he was treated with appropriate therapy, atovaquone and azithromycin, and thanks to that Babesia diagnosis and appropriate therapy, he did fully recover. But he did actually wind up being hospitalized for about 3 weeks before discharge. One of our ID docs actually told me he thought that this guy was going to die, and that's probably because he delayed going to the doctor for so long, and therapy didn't start maybe as soon as it could have. But thankfully, they got him on appropriate therapy after receiving the positive PCR test. So this is another case that's similar in that the initial empiric therapy didn't quite hit the mark. This one, I really understand why, though. So in this case, a 64-year-old woman came to the ED via ambulance at 10 o'clock at night. She had a week-long, intermittent fever, along with body aches, headaches, and pain with urination. And that urinary symptom really threw everybody here. Her initial lab showed elevated liver enzymes and leukopenia. And she was treated with vancomycin and Zosyn because I'm sure they were thinking urinary tract infection and neurosepsis. And of course, they ordered a urine culture and blood cultures. But fortunately, they do have a high suspicion of tick-borne disease, so they did order a tick PCR, also Anaplasma and Ehrlichia serologies. And they did test for CMV and HIV also. But within 24 hours, we were able to determine that she was positive for Anaplasma, and we had that result to the providers. Eventually, her serologies and all the cultures and virology studies came back negative. And, with that Anaplasma diagnosis, she received her full course of doxy, and she was discharged about 3 days after she arrived. So this is another example where we were really able to help get a patient on appropriate therapy faster than we would have if we had been using a send-out test. So in about a year of having this test in-house, these are some of the lessons we've learned. We've experienced a huge cost savings, as I said, in that first 6 months of being live with the assay. We probably saved ourselves close to $1 million. And as we pointed out, we really decreased the turnaround time and, importantly, time to appropriate therapy, which likely improved clinical outcomes in our patients. We also got a better grasp on laboratory stewardship initiatives. We were able to reduce processing of duplicate orders. We were eventually able to reduce what we consider redundant orders, and by that I mean ordering a PCR and serology at the same time in a patient who is acutely ill. we were eventually able to reduce those type of orders via education. And I don't know if this was related or just because we didn't have, you know, a patient that they followed forever that was positive, but we were also able to reduce some of the labor-intensive processes, like the smears, I mean. But again, jury's still out on whether that's related or not. So another thing that I really like is that we have more control over our own data now. When we were sending this test out, I didn't have a great way to search for positives, you know, look and see timing of anaplasma, when we first start seeing it, things like that. It just wasn't as easy to search, send out results in my system. But now I have easy ways to search and analyze our data. Some of the goals that we have for this assay in our lab include regional optimization of our panel. So what I mean by that is sometimes I wonder if I really should have Ehrlichia on my panel. Granted, we offer each assay individually as well as that multiplex panel, so it's really up to the providers to choose. But I'm also curious, should I add the Borrelia miyamotoi? You know, I'm going to wait to see what the University of Maine says about prevalence in our ticks. Another thing I'm interested in exploring is alternative extraction platforms. Our EasyMag is wonderful. It's a workhorse. However, it's a fairly expensive extraction platform, and you know, it's increasingly a problem to obtain reagents for that instrument. So, you know, normally I would take your questions now, but I think if you have questions, you can contact me or DS Warren directly. And I thank you for your time.